So when should you suspect an intra-abdominal pressure to be high? When you give fluids for any pathology, let it be a pancreatitis, let it be an abdominal surgery. So exactly at what level of fluids can we suspect that the intra-abdominal pressure is going high? So Maxwell et al. Recommended that intra-abdominal pressure should be monitored when resuscitation volume exceeds 10 liters of crystalloid fluid or 10 packs of RBCs. Literally like a massive transfusion protocol when you give blood, right? So Maxwell et al. Suggested that when you give 10 liters of crystalloid fluids or 10 units of packed cells, then the chance of bowel going in for edema and worsening of intra-abdominal pressure can happen. So start monitoring them. But Ivy et al. Suggested that a trigger to initiate intra-abdominal pressure monitoring should be greater than when you give around 0.25 liters, that is around 250 ml, 0.25 liter per kg of crystalloid resuscitation, because this doesn't obey any per kg dosage, right? We cannot tell universally for every body status, body habitus or lean body weight. So here by kg, that's 0.25 liters per kg of crystalloid resuscitation if you have did, then the chance of triggering an IAP is going to be more. This is what Ivy et al. Said. But then come Biff et al. Reported that both these cutoffs are ineffective and recommended the following. There is 6 liters of crystalloid fluid or more than or equal to 6 units of packed cell RBCs within a 6-hour period in a patient whose base deficit is greater than 10 is going to be a clear cutoff or clear trigger to initiate intra-abdominal pressure, especially when there is vasopressor requirement also, okay? Because when there is intra-abdominal pressure on the higher side, the perfusion is going to be low, and beyond that you are starting a vasopressor also, which is going to worsen your systemic vascular resistance, which is going to worsen your perfusion. So there the chances of intra-abdominal pressure getting increased, going in for a organ dysfunction is going to be very high. This is what Biff et al. Suggested. So now putting everything into one picture, if you see the initiating event, that is increased capillary permeability, possible because of aggressive fluid resuscitation, whatever it is. So total body third spacing happens. So the water fluid goes for edema, right? Once water goes for edema or bowel edema of that sort, organ tissue edemas of that sort, there will be elevated intra-abdominal pressure. So when the pressure increases, it's going to compress your vena cava. By compressing the vena cava, decreased blood to the heart, that is decrease in preload. When the supply to the heart is reduced, the output from the heart is also going to be reduced. So effectively reduced blood flow to all the organs, leading to multi-organ dysfunction syndrome. So this is what, if you are not judicious with your fluid, you are going to worsen the situation. Okay, this is how IVs is getting compressed. Okay, what happened to the brain? The intra-abdominal hypertension directly contributes to intracerebral pressure elevation, because see, the IVC is here, it goes there, and it can elevate the pressure in the brain also. As far as the lung is concerned, intra-abdominal pressure limits the diaphragm movement. This is going to be the diaphragm. It limits the diaphragm movement, raising the intrathoracic pressures. Okay. As far as the intestines are concerned, it compromises the intestinal blood flow, resulting in ischemia, edema, injury. So the partial pressure of carbon dioxide can suggest you that there is a regional ischemia going on, not a diffuse ischemia. Even a regional ischemia can be formed, and a PrCO2 plus intra-abdominal pressure can be taken as a very good surrogate with a very good sensitivity to identify an intra-abdominal compartment syndrome at an earlier stage itself. Okay. So intra-abdominal hypertension more than 15 till 20, there will be decreased capillary blood flow, leading to anaerobic metabolism, increases cytokine production and capillary leak. This starts at 15 to 20 mm itself. When it increases to 20 mm Hg, the venous return gets impaired, reducing the cardiac output. Okay, so it starts way much earlier. So you need to be extremely conscious in your patients to check whether they are going in for abdominal compartment syndrome. So as far as the vena cava is concerned, we know that IAP anything greater than 12 mm Hg, results in decreased blood flow. For the kidneys, increased venous outflow pressure leads to reduced arterial perfusion and urine production, because of there is less cardiac output and there is direct compression on the renal vessels also. Moreover, when the renal system is not receiving adequate fluid, when the renal system is not receiving adequate blood, the renin-angiotensin system is activated. the renin-angiotensin system feels that the body is not having adequate fluid. So what they do, what usually the renin-angiotensin system does, it increases the water absorption, it increases the sodium absorption. Eventually, it's going to increase your volume in the body. So effectively, it's going to worsen the situation, right? So as far as the heart is concerned, the central venous pressure, the capillary wedge pressure is going to be artificially elevated, falsely elevated, right? Making them difficult to interpret whether it's really a measure. For example, a CVP need not be a real measure of a right atrial pressure. Capillary wedge pressure need not be directly a surrogate of left atrial pressure, okay? So these can be falsely elevated pressures also. So when are you going to suspect? Have a look at this. This is going to be long-standing hernia, and if you pack this up into the abdomen and you start suturing it, there's obviously you're putting more content into the abdomen and the patient can have abdominal compartment syndrome. So it depends upon patient to patient basis or case to case basis. You will be extremely conscious whether any insult in the abdomen can produce an intra-abdominal compartment syndrome. You should start measuring the intra-abdominal pressure, okay? In otherwise situation, there is decrease in urine output, worsening acidosis, hypoperfusion changes like cold, clampy extremities, pale, cyanosed limb, raised peak airway and plateau pressure because the diaphragm is pushed up, and if intubated and ventilated, you can measure the plateau pressure, raised CVP, raised JVP, and hypotension in a normal baseline cardiac status patient, worsening sensorium and increasing ascites. All these things will point out that something may be wrong in the abdomen. When all these things comes, always do measure your electrolytes. Hypokalemia, hypomagnesemia, hypophosphatemia, hypercalcemia, all these things can cause some amount of ileus in the abdomen, right? So that itself can be a cause of increased abdominal pressure. So see for all these things and correct them, okay? So these causes increased intra-abdominal pressure. So this is where you suspect, okay? So once there is a suspicion, you're going to measure the intra-abdominal pressure. It has to measure at least every 4th hourly. If it's more than 12, you call it as intra-abdominal hypertension. If it's more than 20 plus an organ dysfunction, you're going to call it as acute abnormal compartment syndrome. So what is your goal? You need to do everything to maintain the abdominal perfusion pressure more than 60. Okay, how can you do that? You can do by medically by increasing the MAP or decreasing the intra-abdominal pressure. Okay, by increasing the MAP and decreasing the intra-abdominal pressure. So this should be your initial orders when you see a patient in your emergency department. Okay, or when you are called for a code blue situation, you go there and see this. This should be your initial order. So how will you evaluate? What's wrong with this patient? What could have caused this? Is it going to be a primary cause where the abdomen is a primary reason, or it's going to be a secondary cause where because of something else like an ischemia, like a sepsis, and that is causing an abdominal compartment syndrome? That has to be found out, and the risk factors has to be identified. So what are the risk factors? The risk factors are decreased abdominal wall compliance. Number 1, acute respiratory failure, right, where the diaphragm is pushed down, the pressure in the thoracic cavity is very high, the abdomen is literally, the diaphragm is pushed down, so the effective cavity of the abdomen is actually reduced. All these things can cause increased abdominal pressure, right? So next is abdominal surgery with primary facial or tight closure. They have closed the fascia also. So in that case, there's a chance that the patient can have increased abdominal pressure. Okay, major trauma and burns because circumferential burns or even a semi-circumferential burns because of severe pain, the patient can have a tight abdomen. And major trauma where the liver is leaking, where the spleen is leaking, and sometimes post-procedure there can be a rebleed into the abdomen which you can't diagnose on the first day itself or by simple investigations, right? So all these things can be a cause of increased abdominal pressure. Then improper prone positioning. If you're not allowing the abdomen to be effectively distended, to effectively move, then your inappropriate prone positioning can be a cause of restricted abdominal mobility and increased intra-abdominal pressure. Okay, and head and elevation of more than 30 degrees. By head elevation of more than 30 degrees, you're actually compressing your stomach, right? By more than 30 degrees, you're actually compressing the stomach. So these all things can cause increased abdominal pressures. So increased intraluminal contents, for example, gastroparesis, whatever intake you are giving is not, the patient is constipated. So it could be because of pseudo obstruction, it could be because of ileus or just a gastroparesis. So there's increased intraabdominal contents can increase the intraabdominal pressure. Increased abdominal contents like hemoperitoneum, pneumoperitoneum, ascites, liver dysfunction, or blood in the abdominal cavity, a pregnancy, whatsoever reason. So, increased abdominal contents basically itself. Next, increased capillary leak or fluid resuscitation, like the patient is going in acidosis, pH is less than 7.2, hypotension, all these can trigger this kind of CIRS and they can trigger capillary leak, right? Hypothermia, the triad, hope you remember the death triad, right? The lethal triad, hypothermia and the poor coagulation status of the patient can all worsen the situation. Okay, the next is polytransfusion, more than 10 units of blood, coagulopathy. So, there is acidosis, there is hypothermia, there is coagulopathy. These three are called as the lethal triad. Okay. So, platelet less than 55,000 and PT, the prothrombin is more than 15 seconds, or PTT is more than 2 times the normal, or INR is more than 1.5. And there is massive fluid resuscitation like 4 liters for 24 hours. There is evidence of pancreatitis, oliguria, sepsis, major trauma burns, or any damage control laparotomy was done. All these things can trigger a capillary leak. So, that capillary leak can worsen the third spacing, thereby increasing the intra-abdominal pressure. So, if you come across a patient who fits into any one of this, then you can suspect the patient can have intra-abdominal pressure symptoms, intra-abdominal compartment syndrome, if at all your patient has these features also. So, you clinical suspicion, then you are checking for these risk factors. Now, you need to measure the abdominal pressure and then come to a conclusion. Understand, the intra-abdominal pressure should be measured with any of the known risk factors of intra-abdominal pressure is present. Okay, any risk factors plus you are going to measure for sure. So, what is the accurate method? We have two methods, the direct and indirect, right? What is the direct method? You can directly place a various needle using the laparoscopic procedure and you can check it out. You can directly put a catheter into the IVC and you can check the IVC pressure, or intraperitoneal catheters like peritoneal dialysis catheters. All these things you can try, but these are invasive methods, right? It carries its own risk of infection, its own risk of procedure itself. Understand, the more commonly used method is an indirect method. What is the indirect method we use? It's an intravesical catheter pressure measurement. So, we have a box, there is an abdomen cavity and there is a bladder. It is understood that by checking the pressure in the bladder, which can be taken as a surrogate of the pressure in the abdomen. Okay. So, this has become a gold standard due to its widespread availability and its limited invasiveness, right? It's not going to harm the patient much. So, how are you going to do this? So, first, aseptic clamping of the draining tubing of the Foley's. Okay. Then connect the Foley's to the 3-way stop clock. Once you connect the Foley's to the 3-way stop clock, you need to adjust the transducer to the mid-axillary level. Place it at the iliac crest at the level of mid-axillary level. Okay. The patient has to lie down flat. Okay. And zero the transducer at the level of iliac crest. Okay. That's where the bladder is, right? So, then following by around 25 cc of sterile saline into the bladder. And the transducer will now show you the reading. Okay. And make sure that you do this at the end of expiration, because when you inspire more air, the diaphragm is further pushed down and that can cause a false elevation in your abdominal pressure. So, it has to be measured at the end of expiration. This could be your exam question, end of expiration, and the patient has to be in complete supine position, because if you elevate the head, then there could be a chance that you are compressing the abdomen, right? By elevating the head, then there's a chance that you are compressing the abdomen, right? So, the patient has to be at the end of expiration and the patient has to be in complete supine position. Okay. So, what are the contraindications? Understand, there is a bladder trauma. You are going to measure the bladder, right? The pressure in the bladder. What if there is a trauma and the bladder is ruptured? What if there is a trauma and the bladder has ruptured? There is no point in measuring the pressure inside the bladder, right? It's going to be false. Next is, what if it's a neurogenic bladder? It's a neurogenic bladder. It does not have any pressure by itself. Then you have a false negative pressure. What if there is a benign prostatic hypertrophy, a significant prostatic hypertrophy? So, that itself will impinge your Foley's catheter and it can give you a false raised values, right? And now, what about the pelvic hematoma? You have the abdomen and this is the bladder. If there's a localized hematoma here sitting in the cavity, the abdominal pelvic cavity, and that is causing some amount of effect over the bladder, then whatever you are measuring through your Foley's is going to be very high, right? Because of BPH, it can be very high because of direct compression of the Foley's. The pelvic hematoma can directly compress your bladder, causing increase in pressure, increase your measured pressure. The bladder trauma, a neurogenic bladder, can cause falsely decreased intra-abdominal pressure when you measure through the vesicle region. So, the bladder pressure may be inaccurate even if your patient is not sedated or he is not lying flat and he is breathing very, very fast and he is in respiratory distress. You are not able to maintain an end expiration. All these things can cause some amount of inaccuracy. So, this is how you measure. The patient is completely lying flat. Yes, the patient is completely lying flat and there is a Foley's catheter, right? And by the effect of ultrasound or clinically also, you check that the bladder is inside the vesicle. Okay, that's the first thing you need to make sure that the bladder is inside. I mean the Foley's bladder, the bulb of the Foley's catheter, that's inside the bladder. Okay, next you are connecting that to a transducer, right? You are connecting that to a transducer. So, this is kept at the level of mid-axillary line. This is kept at the level of mid-axillary line, okay, and you are going to zero it out. Once you zero it out, it's going to measure the pressure at that point. Now, when you open the stopcock, the fluid enters into the syringe. It's a closed unit, right? Enters syringe. Then stop the stopcock and re-inject this saline into the bladder. Once you re-inject into the bladder and close, the pressure will be transfused and you will be able to see the pressure in the monitor. This is how you need to do it. So, now clinically there was a risk factors and clinically there are some clues that the patient is going in acidosis, decrease in urine, there are some signs of end-organ dysfunctions. So, you are suspecting this could be intra-abdominal pressure increase or you are suspecting abdominal compartment syndrome, and then you are going to measure the pressure indirectly by measuring the bladder pressure, right? So, now it is confirmed that your pressure in the abdomen is on the higher side or the patient is having an abdominal compartment syndrome. How are you going to manage it? Number one, treat the cause. Okay, not only you are going to treat the cause, you can effectively decrease the distress even. Okay, so if there is a decreased abdominal wall compliance, abdomen is not able to move freely because of various reasons. The patient is having severe appendicitis or any peritonitis, the patient is not voluntarily not moving. There is a burn injury, circumferential burn injury, the patient because of pain he is not moving. You need to adequately sedate, give analgesia. If required, if the patient is intubated, you can even paralyze the patient so that the effective muscle tightening is loosened up. There will be little more compliance of the abdomen will be bettered. Okay. Next, remove the constrictive dressing. Abdominal escrotomy has to be done. Avoid prone position and head of bed not more than 20 degrees or not more than the ribbon treatment position. Neuromuscular blockade can be also tried. Okay. Then if it's because of increased luminal content, take out the content. Okay. So, you can put a nasogastric tube, a flatus tube. You can try gastrocolic elements, prokinetic agents like erythromycin 200 mg IV Q8 hourly, metoclopramide 10 mg IV Q6 hourly, or neostigmine 1 to 2 mg IV slow infusion. Look for all contraindications before you administer any drugs. Okay, this all should be given in an IV route, not per oral route, because you are dealing with the GI system. The intra-abdominal pressure is going to be very high. We won't know whether there's going to be poor absorption or not, and moreover, giving more the tablets or the fluid for that sake into the intra-abdominal cavity, into the luminal cavity is not advisable. You're going to keep the patient on continuous RT drainage, right? So, and minimize enteral nutrition. If possible, you can even stop the enteral nutrition. Okay, give some enemas, avoid constipation, empty the bladder and bowel, okay, and colonic decompression as well. If there is increased abdominal contents, like there is an ascites, then you need to go ahead with your percutaneous catheter drainage for fluid. Indicated if IAP is more than 20, you're going to tap it, USG or CT guided. Okay. If still there is an hematoma which is localized, or this is not a drainable fluid, it's a lockulated fluid, like as in case of pancreatitis, you can go in for surgical evacuation. And there's increased capillary leak or because of your fluid resuscitation. So, what to do? First and foremost, avoid excessive fluid resuscitation. Okay. You can use little more hypertonic fluids or colloids or even albumin, which has little benefit or little more oncotic pressure than hydrostatic pressure, right? And try to aim 0 or negative balance by at least by day 3. You can start diuresis once the patient is stable if this is a capillary leak. Understand, we are speaking about a scenario where there is preload decrease, where there is cardiac output is decreased, where there is pre-renal failure, the urea is going to be on the higher side, where the patient is going to be olivuric, till you are going to give diuresis. Because you understood the pathology, that it's not like there is no fluid in the body, it's that the fluid which is available, it's going into third spacing, causing bowel edema. So you give albumin, you increase the oncotic pressure, you bring those fluid back into the normal vasculature, so the cardiac output will eventually increase. Once the cardiac output eventually increases, the flow to the kidneys will eventually increase and there will be good urine output. You can try diuresis once the hemoglobin is stable. If still you are not able to achieve a proper negative balance, you can go for hemodialysis or ultrafiltration. So the medical management being sedation, pain control, neuromuscular blockade, but the brief duration only as a temporary measure, pro-motility agents, fluid resuscitation strategy, body positioning, decompression, renal replacement therapies. Okay. Sometimes you can offer a minimally invasive technique like percutaneous catheter drainage also. And if at all there is a drainage catheter, you need to check out whether that catheter is blocked. Okay. So you need to drain properly and make sure that when you treat a patient, when you start your decompressive procedures, when there is a reperfusion happening, that can start a SIRS. So once SIRS sets in, patient can go in for multi-organ dysfunction, patient can have breathlessness, patient can have ARDS. So be ready to tackle that also. Surgically, decompressive laparotomy with temporary abdominal closures like vacuums, meshes, zippers, pagoda bag. This is a pagoda basically. So this kind of bag you can keep and leave the abdomen open. It's actually more routinely used nowadays for severe intra-abdominal pressures or severe abdominal compartment syndrome. In some cases, you open up the abdomen and rather than closing the fascia, you just close the skin layer, skin and soft tissue layers. Okay, that is one method. That is leaving the fascia open and closing only the skin and subcutaneous tissue. That is option 1. So option 2 is there is limited laparotomy. That is only at the linea alba. Okay, only at the lower abdomen can be opened out. Only the lower abdomen can be opened out. Only the lower abdomen can be opened out. That is the second method. And third, you open and leave it open and cover it with a bag. This kind of pagoda bag. This is the third option. Okay. Either way, it's going to give you a good results, and this has shown a best results. But understand, once you open this, you need to allow it to rest. You need to decrease the edema there, tackle the SIRS. Once the edema settles, once the bowel contents come back to normal, once the MODS everything settles, then you might need to resuture. Even that resuturing has to be without fascial connection. You need to resuture the skin and subcutaneous tissue only. You can do it as a staged process. Once the patient completely resolves and the risk factor is completely out of the game, then the suture can be completely sutured. The suture can be removed, the fascia can be resutured, and the skin and subcutaneous tissue can be approximated. That takes usually 5 to 7 days, but in certain cases, it can go for weeks to months also. Thank you.